والآن مع مسك الختام مع الأخ العزيز وزميل الفاضل الأستاذ الدكتور شريف غازي أستاذ الأندرولوجي بالقصر العيني. هيكلمنا عن جينيتكس اند ميل انفيرتيليتي، وده موضوع في غاية الأهمية علشان الحالات له كلينيكال امبليكيشنز مهمة جدا. اتفضل يا دكتور شريف.
Thank you, Mr. Chairman, for the kind words. Thank you very much. Ladies and gentlemen, my dear colleagues, first of all, I would like to thank Dr. Anani and Dr. Amal for the kind invitation. It's always a pleasure to be with dear friends all around us. And it's an honor to meet with you today. I'm going to present today about genetics and male infertility. And the main question I'm trying to answer in the next 10 minutes is, should genetic testing be part of our routine practice, day-to-day practice in the andrology clinic or when we are managing an infertile patient or not? And to build a base, I would like to know from my friends here, who did order a genetic test for an infertile male in the last 30 days? So the job probably is easy because we have audience who support the idea. There's plenty of reasons why clinicians are not inclined to do genetic testing when dealing with the male. Probably it's an expensive test. Probably some believe that it doesn't have enough clinical relevance and it's only a research tool. Probably it's only psychological barrier. We are not used to order this test. Definitely, it's not because we don't have enough tests, because we have hundreds of tests available in laboratories, which is related to male infertility. Some are related to the chromosomes, others are related to the genes, others, like Dr. Ahmed is discussing now, related to the compaction and the arrangement of the DNA materials, and some of them are related to the gene expression. I think in the next 4 or 5 years, we will hear a lot about gene expression and profiling patients and trying to get the prognosis through the protein composition of whether the semen or the tissues. In my presentation, I will try to focus on few tests related to the chromosomes and genes. And I will start with the simplest test, the oldest test, which is the peripheral blood karyotyping, because it is relatively affordable test. It's available everywhere, and it gives us a lot of information about the number of the chromosomes and also about the structure of the chromosomes. Normally, any man should have 46 chromosomes arranged in pairs, 22 autosomes, and a pair of 6 chromosomes, and X and Y. And when we send our patient to do karyotyping, we expect the results to be positive results or abnormal results when the sperm count is low. So the incidence of positive results is inversely related to the number of sperm. When I send my patient who has 50 million sperm per ml, then I expect that only in less than 1% I will get a positive results in the karyotype. But when I send an azoospermic patient, then probably I will get 10 to 15, there is a 10 to 15% chance that I will get an abnormal karyotype to discuss with the patient. So choosing the population of my patients I'm referring to the testing is very important in order to make it cost effective. One of the most common abnormalities in karyotype related to the male infertility is the presence of X chromosomes to make the constitution of the 47XXY characteristic of the Klinefelter syndrome. Klinefelter, we know, small sized testicles, high FSH, tubular ionization, interstitial Leydig cell hyperplasia. This patient is going by anyhow to micro-TC or to testicular sperm extraction. So why should I do karyotype? Simply because this patient needs to know why he's azoospermic and why he's infertile. Some patients come to our clinic saying, maybe because I was doing masturbation, maybe because this is a football injury. We need to tell him why. Patients need to know. And as a clinician, probably I need to look into the associated probabilities of other disease, for the osteoporosis or for the late slow learning or for the chances of having germ cell tumors. And you, as infertility specialist, when you see a patient with Klinefelter, this will open the floor for you to discuss with the patient the probability of BGD, because we have abnormal chromosomes and probably sperms are abnormal, and we have a number of embryos that need to be examined before returning to the uterus. Leaving the count and going to the structure, this is another abnormal karyotype of a patient with repeated ICSI failure, and we can see there is a part of chromosome 14 is missing, and it's moved to chromosome 7. So this is what we call balanced translocation. Balanced translocation is no problem for the person itself because he have all the materials are within the cell. So he can lead a normal life. But when this cell have to divide into two to form the sperm, the haploid cell, then probably this will affect the quality of the sperm and the quality of the embryos because this division will not be even. So we will end up about 60 to 70% of the embryos having what we call unbalanced translocation. They either have an extra piece of the 14 chromosome or a missing piece of this chromosome. This unbalanced translocation cannot implant, cannot survive. So we will end up with either infertility or with repeated miscarriage, or these patients, if they go for ICSI, they will always likely to face failure, and they will go under the repeated ICSI failure. Though the semen parameters in most of these cases is normal or slightly abnormal. In these cases, probably doing karyotyping and understanding the translocation, that defines the translocation, would help us to guide these people into a BGD. We used to use the fish technique in order to identify the balanced and unbalanced translocation, the normal embryos and the embryos with unbalanced translocation using specific probes. We did that for 10, 15 years. In the last year or so, we start using the next generation sequencing in order to test these embryos. This is a case of repeated ICSI failure. When we did the karyotyping, the male patients have balanced translocation involving chromosome number 4. Lady is young, she's 32, she did her share very well. We have 10 grade 1 embryos, very nice looking embryos. When we do the sequencing, we can see that 6 embryos have unbalanced translocation, either excess part of the 4 chromosome or missing part of the number 4 chromosomes. So only 4 embryos have no translocation. Out of these 2 embryos, one of them don't have Y chromosome, and the other one have excess 10 chromosome trisomy, which is normal for a lady at that age. So out of 10 normally looking grade 1 embryos, there are only 2 healthy embryos ready for transfer. Without the diagnosis of the translocation, this lady will have 10 grade 1 embryos. We are going to transfer 1 or 2. We are going to freeze the rest, and the patients have to go through cycles and cycles of frozen thawed embryo transfer without any results. So sometimes a simple test that looks a little bit expensive would save the patients a lot of hassle, a lot of stress, financial, emotional, and physical. Leaving the chromosomes, which is a very big unit, and going through the genes, which is a very small unit. Hundreds of genes are related to the male infertility, with different level of confidence and different level of reliability. Some of them is related to big groups, like all the azoospermic patients or patients who have failed ICSI, and some of them is very specific to specific disease, like hemophilia syndrome or globospermia. So I'm trying to touch base with an example of each. We all know about the azoospermia factors on the Y chromosomes. On the Y chromosomes, in the long arm, we have groups of genes which is focused in 3 areas. These genes are directly related to spermatogenesis. So when the genes in this area is disturbed, usually the spermatogenesis is impaired. And again, the same like karyotyping. The more severe is the infertility status, the more likely that the results will come back positive for microdeletions. So in azoospermic patients, between 8 and 16 or 17% of the patients have some deletions in the azoospermia factor regions. Should we test each patient with azoospermia for this? Probably yes, or at least we have to counsel the patient and inform them about the availability of this test and leave the choice for them. Is it useful? Maybe. It's useful because, again, patients should be informed. In all the modern medicine, one of the main goals is to keep the patient in control. He participates in the care, and he have to know the situation, and he have to use the tools that educate him, and he have to choose for himself. The second is It's important for the prognosis. The size of the deletion and site of the deletion is directly related to the chance of sperm recovery. So when we have deletion covering the whole isospermia factor A region or B region, the chances of recovering the sperm in TACI is almost zero. While if we have deletions in the area isospermia factor C, still we have 50 to 60% chance to recover sperm. So if this patient have full deletion of isospermia factor A or B, he has the right that I tell him, well, listen, very unlikely to find the sperm. Probably I cannot advise you with the surgery. If you insist, this is up to you. But most of the literature say you have no chance with recovering sperm. And so it empowers the patient, it gives him idea about the prognosis, and most importantly, the vertical transmission. We have only one Y chromosome. So if this father have a problem with his Y chromosome, his son will have the same problem. And this will raise a very ethical, very important ethical point. With ICSI, we are overriding all the natural barriers. Is it ethical to help this guy to bring a child who's also infertile to have the same way of suffering? Definitely, the issue is so complicated because the phenotype is not related directly to the genotype. You can find a family where the father have a deletion, but he fathers 4 boys. 3 of them are isospermic, and 1 of them still have sperm, and he managed to naturally impregnate his wife. So counseling the patient is very difficult. For the last 10 or 15 years, I'm counseling my patients about who have microdeletions that why we don't help you to have a baby girl rather than baby boy and save a child suffering. And I can tell you for one reason or another that I cannot understand, most of the patients refuse. And they want to go with the natural process with no selection. Probably I'm bad counselor, or probably I'm wrong, I don't know. But the fact, none of them, very rare people who accept my advice to choose a girl. Actually, coming to the counseling, one of the problems with the people who have microdeletion is not only infertility, but the problem is that in about 14% of these patients who have microdeletion, they have another problem at the end of the X chromosome and the Y chromosomes in the area called Shox gene region. In this area, sometimes they have either more number of the gene copies, and sometimes they have less number of the gene copies. And when they do this, this will not reflect on spermatogenesis, but it will reflect mainly on the long bone development. So they have a problem with the long bones, especially in the radius and the ulna. And also there's a change in their height. So all patients who have microdeletion of Y chromosomes should be referred to a genetic counselor to discuss with them this problem with Shox syndrome and the possibilities, because it's outside our domain. It's very difficult for us to counsel a couple about such a problem. Another common problem we meet is the bilateral absence of the vase. 80% of patients with bilateral absence of the vase have a problem or mutation in the cystic fibrosis gene on chromosome 7. They don't have cystic fibrosis because they have one sound gene and one affected gene. So it looks like they are carrier of the problem. So these people lead a normal life. If they get married, if we do ICSI for them and the father a child who have the same problem, this child have no problem also. He can lead a normal life. But the only problem if he is bad luck, if the lady, if the wife also is carrier for cystic fibrosis gene. She is normal, but there is 25% chance that the baby will get the bad genes from his father and the bad gene from his mother, and he will end with 2 copies of the gene, and he has the full blown picture of a very nasty disease that he have to suffer all his life about. So probably it's advisable not to test the male, because the male naturally is carrier of the disease, but to test his wife, the wife of each patient who have bilateral absence of the vase, to see if she's carrier for cystic fibrosis gene or not. If she's carrier, then this couple have to go out of the line, go aside, and we start counseling them about BGD and about the cystic fibrosis, about the necessity to examine the embryos. If the lady is okay, then no problems, they can go in the routine practice. For the last 2 slides is covering a very specific problems. One of them is globospermia. Globospermia is not common in our practice, but also it's not uncommon. Patients who have a problem with the acrosomes, either the acrosome is absent, so we end with round-headed syndrome, round-headed sperm, or displaced, or different in size. These patients usually have a problem in fertilizing the eggs, even in ICSI, and there's nothing much to help. Sometimes we use the calcium ionoform, sometimes we use the MC or the high magnification microscopy, trying to find a small vesicle, the remnant of the acrosome. So we choose this sperm with this remnant acrosome to help fertilization of the egg. But in many cases, patients come to you and you have only one question, very clear question. What is my prognosis? Should I pay this money? Should I go through this effort? Should I do this procedure or not? Do you have any prognostic factor? You are helping me with the high magnification. You are telling me about the very big technology you have in your lab. The question is that suitable for me or not? It would help me or not? The only prognostic factor that can help this patient, even for a little extent, is the genetic screening. There are a group of six chromosomes, 6 genes that deletions or mutations in these genes ends in globospermia. Some of them are common, some of them are uncommon. Among these genes, all pregnancies recorded in cases with globospermia either have no deletions in these genes or have a problem with this gene, the DBY19. So if these patients with globospermia run the test to check the 6 genes, if you have any problem with the DBY19L2, this is good news. This patient have a chance to father a child. If you have a problem with the other 5 genes, simply there is no single case reported in literature saying that patients with such gene deletion or gene mutations can father a child. That doesn't mean that he should not do ICSI, but I have to tell him, if your wife got pregnant, you are the first case ever in the world, we are going to report it. If you like to take such a chance, you are most welcome. But if you don't, then I'm telling you from now, it's not an easy thing. Last example I would like just to discuss with you is the primary cilia syndrome, the primary cilia dyskinesia or the immotile cilia syndrome. A lot of small structures helping the sperm tail to move, outward dynein arm and inner dynein arm and the central tubules and etc. Each of these components have certain gene that's controlling its function. Now there are a group of 27 genes that controlling each component of the motor that moves the sperm forward. And when in animal models, when we knock out these genes, it ends with immotile cilia syndrome. So they are really related to the gene. What is the value of examination of this test? Well, it's not diagnostic because we can see that. But sometimes we need to make a closure for the case. Like while you are residents, sometimes they tell us, you can send patient to have electron microscopy. Electron microscopy will see only one sperm. We don't know about the rest. But gene defect will prove once for all that this is diagnosis is right and there's nothing else you can do. When a patient come and said, Dr. X advised me I have immotile sperm and Dr. X advised me to do varicocele. And Dr. Y said I can take treatment for infection. And Dr. Z said that this is partial obstruction, probably we need testicular sperm. Then when you run this panel of the genes and one of them is defective, the answer is very clear. Sorry, you have immotile cilia syndrome, you have to do ICSI, nothing else we can offer to you, case closed. So sometimes you need a closure and genes can help. So my take home message is simple. It might be a little bit expensive, it might be a little bit difficult to interpret, but the key to use genetics in your day-to-day practice is to categorize your patient and select the test very carefully where the positive tests are relatively high So it's cost effective, and it can affect the patient management, and it can help you to tailor a personalized plan of management for each patient different than the other patient. Thank you very much.
ثانك يو. اشكر الدكتور الاخ العزيز الفاضل الاستاذ الدكتور شريف غازي على محاضرته القيمه، ولو كان في اي حد عنده اي issue for discussion welcome. تمام. now we will close the session عشان نبدا السيشن اللي بعدها ان شاء الله. شكرا. متشكرين.